Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis, or a supporter seeking information, or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started.
So as we change gears, we've got Mind Over Cancer. I'm excited for this. This is Amy Durtschi. She's received a master's, I might get this wrong too, in clinical counseling and a PhD in health economics and outcome research. I found it on the internet. It's interesting facts. She's a mother of 3 children, and as of last week, less than 1 week ago, grandmother of her 2nd grandson. So give it up there for Amy.
Hi. Did you see all of this back I see that.
My grandson was born Wednesday after Cripe, so I know. Hi. So I'm Amy Durtschi. I'm the therapist here. But I'm also a breast cancer survivor of almost 17 years. And gave me my second opinion a long time ago. So you should be really glad that I'm here. He gave me good advice. Okay, so I'm going to talk a little bit about the Mind Over Cancer piece, which I love that Dr. Halaharvi gave it that name because it's really true, right? And I know Dr. Delani touched on many of the things that are important with managing your mental health when it comes to having something that for many of us is really traumatic, cancer diagnosis. So, if I look at the audience, by show of hands, if you feel comfortable, how many here feel like they have a sixth sense or they've had a premonition that something's going to happen in their life? Whether it's good, whether it's bad. Am I the only one? No, thank you for not making that any more awkward than it almost was. So I felt like that when I was diagnosed. I have a strong family history of breast cancer. My grandmother, who I was very close to, died when I was 10, so I always felt like this was something that was going to happen. And then it did. And then I always worried it was going to happen again. And I'm sure many of us can relate to this in the audience. So I want to make sure that I talk a little bit about, I'm going to only talk about 2 things in my 5 minutes here. One of them is this premonition aspect of cancer and the mental part of that. And the other one I'll get to. It'll be a bit of a big reveal here in a few minutes. So fear is not a premonition. It's just an irrational thought. And it's driven by anxiety. And if you have this fear of being either cancer returning or something else bad happening, maybe you're not going to do well on your medications, maybe you're not going to do well with your treatment, it has a way of making us believe that we might have a sixth sense and know this is going to happen. So, especially if the first time you were diagnosed, and I'm speaking to those survivors out here when I look out, and I see many, if we felt like the first time that we were diagnosed, we kind of knew that was going to happen, our brain tends to double down on the premonition aspect of it. okay? So this irrational thought is driven by fear and anxiety. It's has emotional and psychological impacts, physical and behavioral impacts, and long-term and other impacts. Just going to touch on them briefly. I apologize, these slides are a little bit busy. The emotional psychological impacts, something that I talk to my patients a lot in therapy, is the anxiety and depression that can come with this. It's a big deal. It takes you out of your day-to-day life. So that constant worry and that fear about the cancer returning can be really stressful and cause a significant amount of distress. There's also a lot of uncertainty, that insidious, I love that word, nature, that cancer can return, can lead to this persistent worry. Those of you that have sat across from me in sessions, I talk about that Rubik's Cube in your mind. You're trying to handle all those emotions and try to help them make sense. By the way, I forgot to mention this, but that premonition also for a lot of us gives us an element of control that we may or may not have, but it helps us feel maybe like the rug wasn't completely pulled out from under us and we knew it was coming. The mental health aspect of it, for many people, cancer diagnosis represents kind of almost post-traumatic stress disorder, sorry, I knew it was a disease, disorder, in our brain. So our actual brain chemistry makes us feel like something really traumatic has happened, and that can be triggered by other things in the environment. If a friend or you see somebody, a coworker or somebody famous gets diagnosed, it can bring back a lot of those feelings. And then there's some numbness, where we just don't take pleasure in the things that we used to take pleasure in. We just feel kind of disconnected, disassociated from life. And the holidays, by the way, is a time when a lot of this can really show up. The physical and behavioral impacts, we become very hypervigilant, right? That's the wake up in the morning and the constant scanning. Am I okay? Am I okay? Is this just a normal headache? Dr. Cripe mentioned it. You know, the worst headache of my life. Is this the worst headache of my life? I'm not sure, but I feel like I have to be really vigilant because I don't want to miss anything. The behavioral changes. You start asking people, am I okay? Am I okay? Am I okay? The next speaker is my dear friend who's heard me ask that question many, many times to her, am I okay? Am I okay? The impact on daily life, that difficulty sleeping and eating and just interacting. Maybe you're at work and you're present, but you're not really there. And then, are you utilizing the healthcare system more? Are you trying to make appointments with all of these panelists to make sure that they can give you some reassurance that you're okay? And then there's this long-term impact of this fear of recurrence. There's an impact on our quality of life, right? It just can impact and greatly affect, for many people, our quality of life, especially if we're trying to be present in front of other people and they're also worried about us and we don't want them to worry anymore. There's those increased in healthcare costs. You know, many of you will reach a deductible just from being the worried well and trying to get the reinsurance that is so vital when you're feeling so scared. And then, are you going to be comfortable making future plans? For some people, that's a really, really debilitating part of this. Okay, last but not least, this is a big deal, it's not that big a deal, but the plan for the emotional side of cancer. So I always say if I didn't have this practice, I would literally sit around outside of the Bing and the Spielman and Mount Carmel, and I would have almost like a doctor's in booth. And I would let people know that when you ring that bell or you have that final appointment or you get that hug from one of these wonderful physicians, you many times feel the most anxious, the most scared, the most sad that you felt during the whole journey. And so if I were to say to you, when you knew you were going to have chemo, if you knew you were going to have radiation, right, you would do a lot of these things that we're being told to do. You would get the vitamin E. You would have a meal train for you. You would have the comfy bras and the comfy, nightgowns and all of those things. We need to plan for the emotional side of cancer. And one of the ways of doing that is the tried and true, and it's been mentioned here, breath work, journaling, mindfulness, meditation. But just know that you're not alone if you start to really feel those emotions. I wish I had both hands, but I always say that you're busy doing all the things of the business of having cancer and taking care of yourself, and then you stop because it's over, and you drink champagne and you ring a bell, but the emotions catch up to you. I hope that resonated. I want to say it's an honor, and I mean this, to be here with you. If you'd have told me I'd be doing this 17 years ago, I would have never, ever believed that. So thank you for your attention.
Thank you, Amy. Appreciate that. I'm really looking forward to this next talk. No more just because it's Jodi Gibbs. She's a PA in her office. She's awesome. She is a bundle of energy. She's the one I said you could maybe hold the microphone down here because we'll find out if we can still hear everything. No, it is nice. You're wonderful. Interesting fact. So survivorship is sexy. Let's talk about it. Interesting fact. Jodi grew up in Plain City, Ohio, in a house that her father built. If you ever started a home project, you know it's easy to start, hard to finish. So it didn't have carpets on the floors for a long time, so Jodi and her sister would roller skate around the house. And to this day, anytime she sees roller skates, she has a little smile. Welcome, Jodi.
You know that runway was really great for a pair of roller skates. Right, later. All right. Okay, so I think I just hit this, right guys? Okay. Okay. All right. How do I go back? I know. I know. There we go. Okay. Yeah. All right, I'm ready now. Here we go. Imagine this. Imagine a woman survives breast cancer. She fought hard through the fear of the diagnosis. She fought hard through the treatments that were thrown her way, whether it was surgery, radiation therapy, chemotherapy, medications, all that affected her quality of life. She has an amazing team around her. She has a team of friends and family that rallied around her to support her. See you all here tonight. She has a healthcare team that provided the most up-to-date care. Her survival of breast cancer is celebrated in the best way. But when the lights go out at night and she's lying in bed by herself and everyone else is asleep, she lies there wondering, is this how I'm always going to feel? Am I ever going to feel desire again? Am I ever going to feel connected to my body again? Is my partner ever going to see me like they did before? That woman is not alone. She represents millions of breast cancer survivors who struggle with sexual health after their diagnosis. Here's what we don't talk about enough. But I'm not good at this. Let's see. Sorry, guys. There. Okay. Here's what we don't talk about enough. Between 50 and 90% of breast cancer survivors report some form of sexual dysfunction after a breast cancer diagnosis. That's 50 to 90%. That means pain during intimacy, loss of desire, vaginal dryness, and perhaps the most difficult of all, a changed relationship with their own body. 18 months is the average time frame for intimacy and sexual activity to occur after a breast cancer diagnosis. And I want to reassure you, if 18 is not a high enough number for you, you are not alone. In my practice, this number is low. 40 to 50% of survivors report anxiety or depression related to their body image. Why is this important? Why do we need to talk about sexual health? Why do we need to talk about these numbers more? Well, because at the heart of sexual health is connection. Sexual health thrives where genuine connection exists, and connection is the essence to human experience. Brené Brown describes connection as the energy that exists when people feel seen, heard, and valued. After breast cancer, many survivors feel disconnected. They feel disconnected from their partners. They feel disconnected from their bodies, even disconnected from themselves. But here's the truth. Connection is not lost, it can be rebuilt. So how do we rebuild it? I did it again. There we go, the 3 C's. Okay, so number 1, conversation. I know that sounds a little sexy, right? It's like conversation really, but conversation is so important. Silence is the enemy to intimacy. Think about the woman we were talking about earlier. She was lying in the dark having those thoughts. And that's when things happen, right? When you're lying in the dark by yourself, when you're driving in the car, when you take a shower and you find every way you can to get out of it without seeing yourself in the mirror. When you dress in your own home and you never thought to lock the door, when you changed your clothes in your own home and all of a sudden the thought occurs to you, I should probably lock the door. It's the silent things that are just never talked about. We have to find ways to start the conversation, and it doesn't have to be heavy and scary and intimidating. It can start with the fun stuff. It can kind of be like, hey, I always ordered your cheeseburger with ketchup and mustard, but do you don't like ketchup and mustard anymore? Do I just totally miss that you don't even like cheeseburgers? Like, what's going on with you? Who are your best friends? Let me see if I can list them, and let me see if I get it right. Like, let me find out more about you. Let's get connected again. There's also sexual intimacy menus, right? You can look at the appetizer, see what do we want for the appetizer? What do we want for the main dish? And better yet, what's off the menu? We can talk about that too. And it's important to recognize that conversation and communication are different. Communication a lot of times can be a one-way street, and it can sometimes lead to a dead end. But conversation is the exchanging of ideas and curiosities and working together to solve a problem. Conversation is important. Compassion. Compassion for both self and partner. Sexual intimacy in a relationship is a dance that you've created throughout your time together. And it's something that just, you know the rhythm. It's like when you hear your song and you go running out on the dance floor. Where's Deepa? I know she goes running out on the dance floor. And for those of you who don't go running out on the dance floor, we know when you're hearing your song. Your foot is tapping, your eyes light up, we know you're feeling the rhythm. And then the song changes, and we don't recognize the rhythm anymore. And compassion is agreeing and committing to staying out on the dance floor, even though it feels awkward and your toes may be stepped on. It's understanding that at one time your partner came up right behind you and put their arms around you to give you a hug, and that felt so good. And then after your diagnosis and surgery, they come up behind you and put their arms around you and you pull away, and it takes you off guard and you're not sure why. And they're caught off guard. Did I hurt her? Is she mad? And it's instead of turning away from each other in that moment, it's turning towards each other with grace, recognizing that you're both going through something that neither one of you had control over. It's recognizing the context of that touch has changed, but not the need and desire to want to be touched. Compassion is the action of loving yourself and your partner. Compassion is important. Care. Care is on us, medical providers. That's on us. We need to fill toolboxes and get resources to you. We need to help you figure out how to start that conversation, how to recognize when the compassion is uncomfortable and you're not sure why. We have to fill the toolboxes, and we have to pay attention in how soon we do it. Timing is important. And I think timing is good when we understand the why as providers. I had a patient come in talking to me about hot flashes, and she's like, Jodi, man, these hot flashes. I'm like, oh, I hear ya, it's hot, you're not sleeping, these are horrible. And she's like, no, I want to stop you there. These hot flashes, I can be hot. I can crack a window, I can have a fan, I can be hot. I'm a mom and a woman, I haven't slept for years. I can handle not sleeping. But my entire marriage, the one thing we would always do is cuddle for a few minutes before we fell asleep. And it always grounded us and brought us back together, no matter what the day held. I got it. Cancer was robbing her of connection. Care is important. All of this does not come together unless we have the V word, which is not the V word that probably most of you thought I'd be saying tonight. I'm keeping it clean tonight. But it's vulnerability. And vulnerability is the courage to stand there to say, this is me, with my scars, with my fear, and with my strength. And it's when the 3 C's, conversation, compassion, and care come together with the V that survivorship gets sexy. Sexual health then becomes not just possible, but powerful. Breast cancer does take many things, it does. But it does not have to take intimacy, it does not have to take desire, and it does not have to take connection. If we can start talking about sexual health with the same courage as we talk about survival, big things can happen. To every family member out there, provider listening, we celebrate survival in the best way. but we often overlook the silent battles survivors face long after treatment ends. Sexual health is not a luxury. It is a vital part of healing, of reclaiming life, of feeling human again. And we play a vital role in finding solutions. To every survivor listening out there, you are not broken. You are not alone. Your story matters. Your body matters. Your pleasure matters. Thank you.
You did not disappoint. That was great. Thank you. Next one, and keep writing questions down on the note cards and passing them to volunteers as you guys have questions. All right, next, stretch, strengthen, thrive. Physical therapy after breast cancer. Angela Kidd's a physical therapist at Nova Healthcare. Interesting fact that she's recently had her second child and now has 2 kids at home under the age of 3, so probably very happy to be here tonight.
Thank you, Dr. Cripe. I'm Angela Gibbs, Dr. Cripe said. I'm a physical therapist at Nova Rehabilitation, actually just down the road near Mammograms. I'm a Revital certified therapist, which is our Oncology rehabilitation program. I'm also a certified lymphedema therapist, which means I can treat swelling that can occur after breast cancer. So what is oncology rehabilitation? Most of you know what regular physical therapy is. It's like the same, but just throughout the whole cancer continuum. As a Revital therapist, we have specialized training to work with cancer patients and understand their complex needs. So your medical team helps get rid of your cancer, and then therapy helps treat the impairments from your cancer. With oncology rehabilitation, we can work on strength, range of motion, balance, pain, endurance, fatigue, cognitive concerns, pelvic health concerns, and then lymphedema. So why is exercise so important? Movement is medicine. I like to say to my patients, motion is lotion. Exercise helps to improve our physical health, our mindset, improve our lifespan. Research shows that survivors who participate in supervised and individualized prehab and rehab programs experience fewer side effects and improved quality of life, improving fatigue, energy levels, decreasing anxiety and depression, improving strength, balance, endurance, improving our cognitive function, and improving the ability to manage cancer-related adverse effects. So what does that look like for survivors? As I mentioned earlier, the exercise guidelines for survivors are the same as the exercise guidelines for the general population. That looks like 150 minutes of moderate intensity exercise per week, like walking, or 75 minutes of vigorous intensity activity per week, like running or jogging, and 2 to 3 days of strength training. I remember when I first learned that, I thought, that's crazy, that's a lot. Like, how am I going to fit that into my week? That's crazy. But that's what oncology rehabilitation helps you figure this out. Help figure out a plan that works for you, what works with you to prioritize your goals so you can achieve a better quality of life. It's normal to lose muscle mass and bone strength with age, but with cancer treatments, that process can be sped up. The good news is that weakness and loss of stamina can be reversed with a supervised aerobic and weight training program with oncology rehabilitation. At NovaCare, we have a specific program designed for breast cancer survivors called our Strength After Breast Cancer program. This is a research-based program that helps decrease the onset of lymphedema and decrease the worsening of lymphedema symptoms in breast cancer survivors. This program is designed to slowly increase weight training so that the body can build strength over time. In addition to decreasing our lymphedema risk, this program improves energy, physical function, strength, and really strives to help survivors live well beyond cancer. Thank you for your time.
That's something we haven't talked enough about in the past, for sure, as a lot of these are, so great. Last, we have your post-cancer screening roadmap, More Than Mammograms by Dr. Amy Harper, a GYN oncologist here at Ohio Health. Interesting fact, grew up in southeastern Ohio, married her high school sweetheart. They have 2 girls, and I hear is a Swiftie. Welcome.
Well, good evening, everybody. My name is Amy Harper. I'm a GYN oncologist here at Ohio Health. I take care of cancers of the female organs. and not breast, but I often kind of intersect with the breast cancer world a little bit because of this post-cancer screening. So let's start here. So how does breast cancer increase my risk of other cancers? So we know that in their lifetime, folks who have a history of breast cancer are about a 20 to 30% increased risk of a second cancer compared to those who have not had a breast cancer before. And there's a few reasons why. It's never just one thing, but one reason, or some reasons, may be your genetic makeup. There may be a genetic condition that led to your breast cancer and may also be associated with other cancers of other organs. So genetics can play a role. Environmental risk factors, things like smoking, our diet, our lifestyle, exposures that we have in our environment can impact our future cancer risk. Treatment-related side effects. There are some chemotherapies and hormonal therapies that can increase your risk of other cancers. Generally, the benefits of those treatments far outweigh the risks of developing these other cancers, but that risk could still be there. And then the final thing is we see you folks more frequently. Once a person is diagnosed with a cancer, especially a breast cancer, you're interfacing with your physicians more frequently than maybe somebody who has not had that experience. So we have a lot of opportunities to talk about what you're feeling and more opportunities to potentially pick up another cancer in the future. So that may be a reason why we see this increased risk of cancer. So some of the cancers that are associated, that we may see more frequently, colon cancers, ovarian cancers, or fallopian tube cancers, potentially uterine cancers or endometrial cancers. And then we have the ones that are kind of universal across the general population, skin cancers and lung cancers, colon cancers. So there are, I may come back to this in a minute, but so we did talk about how your genetic makeup can increase your risk of other cancers. So who might be a candidate for genetic testing? And like we said before, it might depend. It depends on your age, it depends on your family history and ancestry, maybe some characteristics of the tumor that you were treated for. And it could depend on what your oncologist is planning for your treatment plan, where those results may make an impact. One thing to know is that it's more than just BRCA testing. A lot of us have heard about BRCA or BRCA. It is just one of many potential mutations that can increase a person's risk for breast cancer, among others. So when you are talking with your physicians about your breast cancer, your family history of breast cancer, it may be more than just testing for that BRCA gene. We usually will perform something called an expanded panel test, depending on your family history, that may pick up another mutation that could have impacted your developing breast cancer. And that's going to change what we screen for in the future for you, potentially. A couple just general characteristics that we may see. If you were age 50 or under with a breast cancer, you would potentially be a candidate for genetic testing. If you were any age with a breast cancer and it was a triple negative breast cancer, or you had multiple breast cancers, a type of breast cancer called lobular breast cancer, plus a personal history of a stomach cancer or a family history of a stomach cancer. If you are a male with breast cancer, or if you have breast cancer plus you descended from the Ashkenazi Jewish ancestry, you may be a candidate for genetic testing. If you have one or more close blood relatives, that's usually a first degree brother or sister, brother, parent, grandparent, aunt, uncle, with ovarian, pancreatic cancer, a male breast cancer, or certain types of prostate cancers, you would be considered a candidate for genetic testing. And then if you have more than 3 relatives on the same side of the family with a breast cancer, you may qualify as well. And there are other features and other characteristics that may flag as a reason test for those germline or those inherited cancer conditions. So talking with your oncologist, or if you're plugged in with genetic counseling, is very important because there are definitely more than this. Screening guidelines. So we do have screening guidelines to follow for all different types of cancers. And a lot of times it's going to depend on your genetic makeup. For folks who don't carry a genetic condition, we kind of follow the routine as general population recommendations. So yearly skin exams with your dermatologist, colon cancer screening, we're getting earlier and earlier starting colonoscopies, and the frequency of those depends on your the findings of your first colonoscopy and your family history, but currently is age 45, sometimes younger. You're all too familiar with mammogram screening. That's important for some folks too. And then we think about the GYN world, and that's where really I come into play. And so some of these genetic conditions are kind of closely related to GYN cancers, and so do these change based off of that finding? So again, it depends on your genetic risk factors and your prior medical history for some of these. But for ovarian cancer, we don't have a good screening test. That's really disappointing. Maybe we'll find it someday, but even for folks who are at increased risk because of their genetic condition, we don't have a good screening test. But a lot of times you'll talk to somebody like me, a GYN oncologist, that's gonna talk to you about how do we reduce your risk. And depending on your age and your goals for fertility or your life, we might talk about doing an every 6-month ultrasound with a tumor marker called CA-125 to sort of monitor for any changes, but what we know is that this is not really good. We aren't good at changing the ultimate outcome of an ovarian cancer diagnosis, in other words. But more than likely, we are gonna talk to you about risk-reducing surgery to take out those tubes and ovaries before they become a problem. But generally, it's a yearly physical exam with someone who knows GYN organs, like a well-versed primary care provider or an OBGYN who can do a pelvic exam and ask you about some important symptoms. Uterine cancer or endometrial cancer, again, we don't have routine screening for our general population for folks without a genetic condition that would increase your risk of uterine or endometrial cancer. And that includes people who are on tamoxifen. So tamoxifen does have a very low risk of developing and causing an endometrial cancer in the future. But for folks who are on that tamoxifen, there is no special screening for you. We will talk about what to watch for with that. But if a person does have a genetic condition that increases their risk of uterine or endometrial cancer, you may be recommended to have periodic biopsies of the lining of the uterus, or an endometrial biopsy, usually every 6 months. This is in folks who carry a genetic condition called, or have Lynch syndrome. And again, you would be seeing somebody like me for that. And again, more than likely, we are going to be talking about risk-reducing surgery for you in the form of a hysterectomy and removal of tubes and ovaries before it becomes a problem. But most importantly, it's a yearly physical exam and monitoring of symptoms. And then finally, we have cervical cancer. So cervical cancer does have a good screening test. Finally, something that works. So we have the pap smear, pap test, and usually this is performed with HPV testing, or human papillomavirus testing. Cervical cancer is caused by human papillomavirus in over 98% of cases. This is one of the biggest developments in the history of the world. Okay, I'm not even underestimating that. We could eradicate cervical cancer because of this testing. So we start pap smears at age 21 and continue through age 65 and sometimes even older, depending on what your pap history is. And the interval depends on your prior test results and your age. And one way that we can prevent cervical cancers and other HPV-associated cancers is with the HPV vaccine. And so there are a number that we can prevent. And what we know is that HPV vaccination could potentially eradicate these HPV-related cancers. So HPV vaccination is recommended for everyone, male, female, anyone in between the ages of 9 and 45, regardless of your pap smear history and exposure history. Get it, okay? And get it to your kids and get it to everyone you know. Put me out of a job, please, okay? But let's go back a little bit and talk about these really important symptoms that we've kind of been alluding to this whole time. So what are some symptoms of cancer that you should never ignore, especially GYN cancers? Postmenopausal bleeding, not even a drop, not a spot, no matter how little, how infrequent, or how frequent. Always, always, always abnormal. See your OBGYN, talk to your primary care doctor about it, get evaluated. It needs to be evaluated. You did not start your period again. You did not sync up with your daughter, okay? This is not normal. Please come see me. If you see bleeding with intercourse, always, that's an important symptom as well. If you see blood in your urine and you don't have a UTI, it may not be coming from your bladder. It may be coming from your uterus. So please, again, no blood ever. If you feel changes in the way that your urine moves, pressure on your bladder, increased frequency, increased urgency, it's different from your norm. You don't have a UTI, it's still there over the course of a week or two. Get evaluated. Profuse, foul-smelling vaginal discharge. Most of the time it's going to be an infection or something, but if it's not, you need it to be evaluated no matter what. But if it doesn't go away after your treatment with antibiotics or whatever, you need to be evaluated again. Something that nobody wants to talk about, vulvar itching and irritation. I can't tell you how many patients I ask about this symptom, and they'll say, yes, I've been dealing with this for actually years. And this can be a symptom of vulvar cancer. So persistent vulvar itching or irritation, generalized abdominal discomfort, bloating, changes in your appetite, or getting full quickly, and weight loss that you don't need to do. Okay, these are all super important. Definitely not all encompassing. GYN cancers are sneaky, they're vague. Be vigilant, and it's okay to be persistent. If you feel like there's something wrong and you feel like nobody's listening to you, it's okay to be persistent and say, hey, can we look into this further? And this is a way that we can kind of prevent some of these cancers. So breast cancer screening after a breast cancer diagnosis changes a little bit, especially if you have a genetic condition. But I think the most important thing is that we don't let those things go. We made it through our breast cancer treatment, yes, onward, but we want to then take that and be empowered to continue to live our lives in a healthy way. Okay. All right. I appreciate everybody's time. Thank you so much.
Great, thank you. Thank you to our panel. And again, if you have any questions, please write them down. We have a couple questions here, not too many. For people that aren't going to be in the fashion show, if you haven't changed already, please grab dinner and then get changed. I guess even if you have changed, grab dinner so that we're ready for the fashion show. Otherwise, we're going to get dinner for the rest of us here in a little bit. Fill out your post-test survey, so you now should have learned everything. All right. Asking for a friend. What's the number one thing you recommend husbands or partners do to help with recovery? Here, first. Asking for a friend. The number one thing you recommend for husbands or partners to do to help with recovery. Could be emotional.
Yeah, I mean, first of all, that's a great question. It depends. No, kidding, totally kidding. I think, if I think back to my husband, I saw him cry one time, and it was the morning of my mastectomy. And he was in the shower and he didn't want me to see him. And I know that he probably cried more than that. He swears he didn't, I don't believe him. I think I see a lot of women that want to manage everyone's emotions around them. And there's this chasm that's created between partners and family members and children and friends, and everyone wants you to be better. And if you can just say that I will be better, but it might not be today, and please don't be scared of that. You know, I think it's just like anything, communication is the key. And, you know, I mean, it's not uncommon for partners and spouses and family members to also seek mental health counseling. So shameless plug. If they're dealing with some of those emotions too, because they can have collateral anxiety and depression. Do you want Jodi to?
Sure.
Conversation, not communication. Did you hear what I said? No, just kidding. I'm kidding. No, so I do think that we do talk to a lot of people who, as a couple, have never talked about how they felt. You know, if they were afraid, what that looked like, how that, and so I think conversation's good. I also think that I have found that a lot of times the partner isn't even sure how to even touch the survivor again. They're afraid they're going to hurt them, and so it is even going through. There's different exercises you can do just to spend time together and learn what touch feels like again and what you like or not. So it is finding, like, is there a sex therapist to talk to or a behavioral therapist? You don't have to go to that degree, but it is recognizing that you're both experiencing this for the first time, and it's okay to be vulnerable in that space.
What are the treatment options and what is courting?
Coordinating is something that can happen after surgery treatments. It can be a tightness that you can feel often in the axilla. It can be down into the elbow, into the wrist, anywhere kind of in that arm. But any sort of tightness that doesn't really go away. Oftentimes patients will say they can feel it when they do something certain. You can sometimes actually visualize it under the skin and or feel it. You can kind of pop your finger over it. What do we do for it? Is that the second part?
Sure.
Okay. We do exercise for it. We stretch, we kind of work on moving that joint, getting that moving better. The manual techniques we can do, so we were hands-on helping to stretch that cord and loosen it up. Oftentimes that kind of helps improve that function of that joint wherever it is, and gets rid of that cord.
Since you have a microphone, I have a question from Dr. Torrey's table. What do you do for patients that have that abdominal swelling after the deep flap? When do you start rehab?
Good question. It depends. It depends on type of surgery, surgeon preferences, things like that. But usually within the first couple weeks after surgery, we can start treatments or therapy. What we do for that abdominal swelling is movement. We do exercises for it. There's also hands-on techniques, manual lymphatic drainage massage we can do to help with that area. Diaphragmatic breathing, lots of things to get things moving again.
We'll go down our last question here. Comment on the removal of the fallopian tube versus the ovary when you're trying to reduce risk of either for BRCA or for someone who's had ovarian cancer.
Yeah, okay. So if you've had ovarian cancer, chances are your ovaries and tubes have been removed already. But for people who have just a genetic condition that puts them at risk for fallopian tube or ovarian cancer, it depends on your age. Right now, our current recommendations are removal of both tubes and both ovaries. There's a very specific way that we do this, and that's an important thing to talk about with your surgeon about the technique that they use and the components of that removal of tubes and ovaries. There is an ongoing study right now looking at just removal of tubes. So for folks who are premenopausal, we know that the ovaries are so important. And supporting your overall health, bone health, heart health, brain health, all these things. And so for folks who are premenopausal, they may not want to get their ovaries out too early. And so right now there's a study ongoing looking at just removal of fallopian tubes before the age of menopause, so that you can hang on to those ovaries as long as is safe. But some things that kind of depend on the timing is with your genetic condition. For BRCA1, a lot of times we're talking about removal of tubes and ovaries by age 35.
For BRCA2, we might push that out to 40. There are some other genetic conditions that we're pushing out a little bit further. And so I don't know if that's going to end up changing from this study that's coming out. But for folks who are, in their 20s, and it depends on your family history. If your earliest family member with fallopian tube or ovarian cancer was 30 or, super young, you may not want to wait longer. But the study that was coming out hopefully will be able to answer that. How long is it safe to hang on to those ovaries? We think most ovarian cancers do come from the fallopian tube. So that's where that's coming from.
Great, thank you. Thank you, Anna. Appreciate it. Dr. Harvey.
Give it up for panel 2. You guys did an outstanding job. Very good. Thank you so much for being here, taking the time to educate us and empower us. We really appreciate it. How about the moderator?
Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer, this podcast is not intended for complete medical advice, so please talk to your medical professionals.